Yeah.
Good evening. I welcome you all to the webinar on by the Chennai Menopause Society on Geripause challenges and solutions. I request our Chennai Menopause Society President, Dr. Shanti Gunasingh ma'am, to deliver the welcome address. Madam.
Yeah. Good evening to one and all. Yeah, it's okay. Good evening to one and all. It is indeed our pleasure.
Are you driving?
No, madam, I've stopped by the side. So, good evening to one and all. It is indeed my pleasure to invite you all to the webinar on Geripause. See, that word at least, should be familiar to us, menopause practitioners. And we keep on reiterating about fall prevention and sleep. So that is the reason why this has been included again. And it is indeed my pleasure to invite Dr. Maninda Ahuja, who has been a very active IMSian. That's what I should say. And active literally too, in all aspects, physically, otherwise also. I've seen her, I think, since 25 years when we were in the managing committee. Really a very active person. It is really nice to have Madam here as our chief guest. And of course, it is our pleasure to have Dr. Madani Madam as our guest of honor, who's really looked upon by all of us. And her zeal for learning still really actually makes us read more and more. And she's Madam, really, we are happy to have both of you all here. And the topics have been chosen with care so that all menopause practitioners will benefit. I'm very happy to invite the faculty, all of them, all erudite faculty and the erudite chairpersons who are really going to add value to this program. Welcome one and all.
Thank you, ma'am. So next, Tamil, we'll go for the Tamil Thai Vartha to begin the program with a prayer. We'll begin with Tamil Thai Vartha.
Okay, ma'am.
நீனாரும் கடலுடுத்த நிலமடந்த கெழிதொழுகும் சீனாரும் பதனமென திகழ்வடத கண்டமெனில் தெக்கணமும் அதில் சிறந்த திராவிடனை திருநாடும் தக்க சிறு திரை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வழங்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்ந்ததுமே வாழ்ந்ததுமே வாழ்ந்ததுமே.
I now request Dr. Rajalakshmi ma'am, Professor of SMCH, to recite the midlife prayer.
Midlife prayer: changes, not challenges. Preserve, protect, and promote. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength, guide our heart, our mind, and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for a healing touch. On this day, May all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others. Thank you.
Thank you, ma'am. To away the darkness of ignorance and brighten our lives with knowledge, let us begin by lighting the Kutuvilak. I now welcome our chief guest, Dr. Maninder Ahuja ma'am, who is a consultant. Sorry, ma'am.
Madam CV Ma, Sahiti.
I now welcome our chief guest, Dr. Maninder Ahuja ma'am, who's a professor and president, Society of Meaningful Life Management. She's a director of Ahuja Healthcare and Infertility. Madam has been vice president Foxy from 2013 to 2014 and vice president SAFOMS for FOGS founder member. And she was a president of Indian Menopause Society from 2014 to 2015. And she's affiliated with many professional bodies like ISR, SPAT, Foxy, and she's editor-in-chief, Journal of Midlife Health 2022 to 2024. And Madam was a founder of Faridabad chapter of Indian Menopause Society and the founder member of SAFOMS, NACHI, Haryana chapter of ISR, FOGS, Faridabad chapter of SPAT, and Faridabad Menopause Society. Ma'am, proponent of preventing health exercise diet has been ma'am's research, and she has more than 130 publications in journals, textbooks as authors and editors, and many original researchers with more than 230 citations of scientific articles. She's a thought-provoking leader, and she's a website in charge of Indian Menopause Society, many awards and recognitions to various professional organizations. Ma'am, we request you to address the gathering.
Thank you, Sandhya.
Madam is actually looked upon as a fitness specialist. So welcome, Dr. Maninda.
Thank you, Dr. Shanti. Good evening to everybody. And it's an honor and privilege to be invited by the Chennai Menopause Society. And perhaps this was the one society when you had your annual IMSCON, I think way back in 2009 or 8. And I had given my first stage performance at that time during IMSCON conference, along with my lecture series, of course. So I must thank our past president of OXY, Dr. V.M. Madhini, our president, Dr. T.K. Shani, our secretary, Dr. Meera Raghavan, who is there, Dr. Chairperson, Dr. Manu Lakshmi, Umam Keshwari, and our topic today is very, very interesting, the Geripause challenges. And Dr. B. Balakumari will be talking on that. Is menopause sleep pause? Dr. Nilina, fall prevention by T. Karthik Rao. Now, all these topics are really very, very close to me. I'm audible, na? I'm audible?
Yes, madam.
Okay. Yes. So now menopause is a actual physiological process in the reproductive lifespan when it ends and the new phase shuru. But sometimes it's does not remain physiological process and changes into pathological process because of the hormonal changes which are occurring. Now, does menopause occur in all the mammals? No, it does not. So it occurs in the blue whales. Otherwise, it's not occurring them. Chimpanzees is occur. So the species which have menopause, they have a longer life. And they say the life is extended so that they can look after their children and grandchildren. So that is the theory which is going on of how it evolved. In India itself, by when it was around independence year, 47 years, the life expectancy was very less. So very few women used to reach the age of menopause. So that's why it evolved as a specialty very late. But now, as the life expectancy is increasing, so is the number of women, and so is the problem we are experiencing with the menopause. So now in all over world, about 400 million women are menopause and 40 million are being added every year. Same way in India also about 14 million, I think, menopausal women every year being added. Now, when do the problems of the menopause start? Do they start with the menopause when we don't have a period? No. It starts much earlier. That is called the menopause transition, when actual the fluctuation of the hormones occur. So they say initial symptoms are because of that fluctuation of hormones. So perimenopause is the transition period when the first symptom might be an irregular period, more than 7 days, plus or minus. Then start with that the DUB, abnormal uterine bleeding problem. And then comes the changes of hot flushes and menopause rating scale, symptoms of irritability, of sleep problems, of myalgias, of mood changes, of the genitourinary syndrome of menopause. And then comes the changes in the other areas where the like osteoporosis, cardiovascular disease risk is there. Now, when today we are talking not only on menopause, we are going to Geripause. So Geripause, I looked into that one, that actually it was not defined earlier. Now, somewhere papers are defining it, that from menopause, the average age of menopause, they think is 50 years, but in India, it's occurring 6 years earlier. And that study, last study was done by me only, that it's a 46 years, 6 years earlier than our Western counterpart. So that means all these problems which we are having in menopause in India will be occurring 6 years earlier. So along that, then from 60 to 65 years, they say, is the menopause. Then 65 years to 80 years is the early Geripause, and 80 years beyond is the late Geripause. Now, what changes then occur? Earlier changes are because of the low estrogens. So we have to look into that estrogen therapy. But later on, what happens? They are because of the aging processes. More are because of the aging processes. So that's why kidney involved, heart involved, bone osteoporosis involved. So maximum fractures are occurring in osteopenia also, and later on ages also. So we have to do prevent that also. And we have our experts sitting with us who will be talking on those problems. So I think it's going to be a very, very beautifully organized webinar where all of us will be benefited, and me also. So I'll stay with you people till the end. But I think I won't be taking much of your time so that the webinars can end in time. So we should not be extending them unnecessarily. So again, my congratulations to all the Chennai Menopause Society. It's really an honor to be here, and I will gain by listening to all these panels and the speakers on different topics. Thank you very much to you, all of you again.
Thank you, ma'am. We now request you to release the medal, ma'am.
Okay.
Madam, this is the 18th edition of our menopause associated disorders awareness letter. So all
Very good.
these
Very good.
webinars are sent as e-newsletters.
That is excellent, because all of us are going digital, and let's go digital was, I think, first of all, I started talking in Foxy when I joined in 2008. So I said, let's go, let's reconnect Foxy. Then I have made registered my own society, that is Society of Meaningful Life Management. Please go to website of smlm.in, and there you will find lots of public awareness and information and exercises and everything. And I'm finding that your newsletter is excellent. I have gone through in this time all the pages when you were going through it. And it's a good idea, excellent idea that you are sending it to all the societies. Please circulate it. We will also circulate it. Better to send it to IMS, our secretary, Paresh Patel, and
Yeah,
ask
no,
him to circulate. Yeah, ask him to circulate
we
in
put
all
it in the group, madam.
Yes. No,
Yeah.
not in the group. Send it to Presh officially to circulate it in all the societies. Okay? Because
Okay.
we have different groups of all the societies also. So they can be circulated in all the, because whatever work, if it is done and if it's not reached to the masses and classes, it's efforts of those who have done lots of hard work goes wasted. So that's why I'm requesting you to go to the website of Indian Menopause Society, SMLM, also go to that website and you can gain a lot. And welcome again to all of you. And my namaskar.
Thank you, madam. Namaskaram.
Thank you, ma'am. We now request our guest of honor, Dr. V. Madhini, ma'am, who is a retired professor and HOD of Department of Obstetrics and Gynecology from Madras Medical College, and she was a former director of Institute of Obstetrics and Gynecology, Chennai, and she was a past president of OXY, UG and PG teacher for more than 45 years, and has been examiners in various universities, and she has been an advisor in UPSC and given several orations, and has been chairperson speaker in conferences, and she has presented papers in various national and international conferences. And she has contributed to OG textbooks, and Madam is interested in high-risk pregnancy, medical education, and traveling. Ma'am, we request you to address the gathering.
Thank you. Good evening. It's indeed a
Good
great
evening,
pleasure
madam.
for me to be the guest of honor for this webinar on Geripause, challenges and solutions. Am I audible?
Yes,
Yes,
madam, very much.
I thank the President. I thank the President of Shanti, the Secretary Dr. Meera, and their CMCN team for giving me this opportunity. The Chennai Menopause Society is very active and effective in disseminating knowledge through webinars, conferences, and model regarding midlife, and conducting camps, counseling for this group of women, for this midlife women. Congratulations to you all, CMCs. Geripause is a term coined by Dr. Bernard Eric, SK, in 2003, and he defined it as the phase of menopause after the age of 65 years. 65 to 75 years as early Geripause, and over 85 is late Geripause. And our chief guest said because our age of menopause is earlier, so she put it between 60 and 80, right? Okay. This during the reproductive life, estrogen fluctuates around 300 per milliliter. It gradually decreases during transition to menopause, and eventually, over the age of 65, early Geripause, the estrogen is less than 10 micrograms per milliliter. This lack of estrogen leads on to all these changes in our organ, all the organ systems. According to World Bank, which has collected the data from officially recognized sources, in 2023, it is going to be around 7.5% of the Indian women were over 65 years. And by 2030, 50% of the women will be postmenopausal, and among half of them will be in Geripause. So every woman has to go through these phases and experiences, and accepting the midlife changes gently, as you said in the prayer. And we are as the caregivers, we have got to find the solutions. So today's webinar is on Geripause, challenges and solution. Challenges will be dealt by my friend Dr. Balakumari, and the solutions regarding sleep by Dr. Lima, a psychiatrist and a sleep specialist. and fall prevention by Dr. Karthik Rao, specialist in his own field, and then a panel. My best wishes to the speakers, their guests, and all Chennai Menopause societies. Thank you.
Thank you, madam.
I just want to announce one thing. This year in Indian Menopause Society, I have started a rural committee award for those societies who give us work in the rural areas. Where like Surakshit Matritva Yojana, once in a month only, the societies will adopt a village, and once in a month only, 3 or 4 doctors will go to that village, talk about menopause in vernacular language, and just collect some data of 30 women or so regarding menopausal symptoms, height, weight, BMI, and hemoglobin. That's all. After 3 months, they go back there and find out whether their talk had given any effect or not. I think that way we will be creating an awareness about in the rural area, because at this time we are just sitting in the urban areas. Might be in South India, we have some centers working in the rural area, but in North India, we just are restricted to the urban areas only. So the societies who do the good work will better work will be awarded during the IMSCON. And I think that will create more awareness about the menopausal problem. And we reach out to the people that way. Not that the people coming to us, we reach out to them. So that is one way. Thank you.
Thank you, madam, for the nice suggestion. Thank you.
I've already donated money to the menopause for. Okay.
Thank you, ma'am.
Thanks.
Moving on to the scientific session, I welcome the session 1 chairpersons, Dr. Manu Lakshmi ma'am, who is a consultant obstetrician gynecologist and director at the Gunashekaran Hospitals, Chennai. Ma'am has contributed to book chapters in sexual medicine, principles and practice, Springer publication, and her areas of interest are high-risk obstetrics and reproductive endocrinology, mountaineering and mixed martial arts. And our second chairperson, Dr. Uma Keshwari Venkatesha. She is an American board certified physiotherapist currently practicing in Chennai and head of pelvic floor physiotherapy in Juho Health. She's graduated from MMC in 1987 and has been practicing ever since 1988. She has presented papers in national and international conferences and has conducted workshops for training the physiotherapist on pelvic floor dysfunctions, creating awareness about pelvic floor health among school and college children, employees at IT companies and Women's Forum. And Madam has received Best Physiotherapist Award from State and National Indian Association of Physiotherapists Conference for her 2.5 years study on interferential therapy for incontinence. We welcome you, ma'am. We request the chairpersons to introduce the speakers, ma'am.
Good evening. It's an honor to be here in such an august gathering. And it's my honor to introduce and welcome Dr. Balakumari, who's been a guiding light for me when I started my practice. She did her DGO and MD from MMC Madras Medical College and a diploma in assisted reproductive techniques from Germany, and she's been the past founder and past president of Velachery Indian Medical Association, and she's also had the honor of being awarded Mathu Nachatram by IMA and Hindu Tamil Tisai, and she graduated with 3 gold medals, and she has been very active in teaching with and also has a YouTube channel of her own. Currently, she's a lead in lead clinical obstetrician at A4 hospitals, and also a very active executive committee member at OXY. Welcome, madam. It's my honor.
Thank you. Thank you. I thank Dr. Shanti Gun Singh, Dr. Meera Raghavan for giving me this opportunity. I'm extremely happy to participate in this program. Thank you, Dr. Manu, my friend, young friend, and Dr. Uma. Uma, she's a physiotherapist who is who has helped us to do a better job of this menopausal symptoms and pelvic floor deficient patients in our hospital. I will introduce, thank you for the introduction. I will start with the topic. Sahite, can you change the slides for me?
Yes, ma'am.
My introduction slide was some messed up. It was, the words were going to and fro. Next slide, please. Menopause is a magic time for some people. It's a sad, dramatic farewell party for some people. A magic time because at around 45 to 50, if you had been in a career, you would have reached a better position. You would have accumulated wealth. You have time to do things that you want. Your children, if you had got married and given birth to children at the correct age, your children will be somewhere around 20, 17, like that, when their exams will be over. So you can start doing something on your own. I started my hospital after my menopause. And for those people who are getting married late and thinking all is okay, I'll achieve something in life and then get married and have children, that is a very sad and unacceptable event if it is a little early menopause, especially. And for people who had been trying for pregnancy, didn't happen, wanted to have a baby, and they decide to have after 40 some IVF or ICSI, those women again find it very difficult to accept the menopause so easily. And even women who are very active, when they start getting menopausal symptoms, nowadays some people come and tell me, I'm so worried and scared about getting a menopause. Next. The most important symptom that is very obvious is the hot flashes and night sweats that wakes the woman get up drenched. When everyone says they are shivering in the AC, the woman feels it's burning. And whatever you say, the family feels you are exaggerated because of late they had seen your mood swings and they think you are exaggerating. Next. The mood swings, thanks to the fluctuating hormones, emotions become as unpredictable as the weather. Your family is not sure whether you're going to hug them or grumble that no one appreciates you. And the sudden rage when you see a wet towel on the bed. The sudden rage when the husband doesn't know where he kept his key and keeps asking you, where did I keep the key? Search for me. So this sort of rages, again, is going to be a nightmare for the family. Next. Anxiety and depression. Some people are anxious about the menopause, about their children, because even though on one way it is a relief that they have done their schooling, what are their career is going to be, how are they going to prepare for that? And your husband might be getting ready for the retirement. What are you going to do with the finances? How are you going to manage? All this. And some unexplained depression might be the symptoms which troubles the woman. Next. Sleep, again, generally, especially obstetricians, many of us find it very difficult to have a peaceful sleep all these years because of the obstetric practice, and adds to that the perimenopausal changes or the menopause. We keep advising the women for an 8-hour sleep a day, but with the night sweats and an overactive brain, which keeps thinking all about your past, at 3 a.m. in the night, sleep becomes a luxury, which happened to me as well. Next. Next. Can you change? Yeah. Again, the changes that happen in the shape. You seem to be eating so healthy. You seem to be doing all the workouts. You are working 16 hours a day, but then you put on weight in unnecessary areas. And suddenly you feel your blouses have shrunken. Turns out that menopause slows down the metabolism. Maybe we should start taking less than what we were taking actually. Next. Added to that, all aches here and there, a migraine might get aggravated, osteoarthritis might start, bone weakness, joint pains added to the workload most of us have around this time, because sort of we will be reaching towards the peak of our career when the workload is more for all of us. Next. Memory loss. Again, there's an obvious loss of memory. You will be wearing your glasses and then searching for the glasses. You will have your phone in the hand and then searching for the phone. And all this brain fog, again, makes it very difficult. Next. Change the slides, ma.
I have changed, ma'am.
Yeah,
Are
yeah.
you able to see it,
Yeah,
ma'am?
yeah, I can see. Definitely loss of libido. It is not just the dry vagina. The dry vagina may come a little later, but the loss of libido, maybe because of the hormonal changes, maybe because of the overwork, maybe because of the anxiety and tension. Definitely, it is difficult for the other partner to cope up with it. It may be okay for you, but the partner might find it difficult. And they may have increased libido at that time. And again, your mood swings definitely makes it very hard. Lubricants, estrogen creams can help. And definitely an understanding partner will be able to adjust. Next. So how do we survive this? I think we'll have a panel at the end of this session. So we will stop with this slides. I once again thank all the members of the Menopausal Society for giving me this opportunity. Sahiti, you can switch over to the next speaker now. So this is all in the last panel discussion part. To sum up, the menopause can be a boon or a bane, and how we are going to accept it, how we are going to educate the patients, how we are going to treat. Not everyone might be willing to take up a hormonal replacement therapy. In fact, in my practice, I've not had, it is less than 1% of the women who accept a hormonal replacement therapy. When you're honest and tell them, this is a hormone, this can have a few side effects, then they say no. And of course, calcium and the other antidepressants, they may take for a short while and then they discontinue. Many of them, sort of in our country at least, they prefer to undergo the suffering, then ask for help a little later when things become worse. Sagiti, you can stop sharing my slides and go to the next speaker.
Thank you, ma'am. Moving on to the next topic, menopause and sleep pause. We have Dr. Neelina as our next speaker. Madam is a psychiatrist and sleep specialist. She has done her undergraduation from Government Medical College, Kottayam, and MD Psychiatry from Government Stanley Medical College. She has completed her fellowship in sleep medicine and diploma in pediatric sleep medicine. Madam is assistant professor at Sri Ramachandra Medical Center and consultant at Mitra Institute of Sleep Sciences. And she's a member of Indian Sleep Disorders Association and Indian Psychiatry Society. And she's author to various publications, has given numerous talks at scientific programs, participated in various awareness and outreach programs through TV shows, radio shows, talks, printed media, etc. And areas of special interest are sleep medicine, liaison psychiatry, and medical education. Ma'am, we request you to deliver your.
Hello,
Ma'am, you're muted, ma'am.
Is it better now? I just switched on the.
Yes, ma'am.
Yeah. Yes. So good evening, everybody. So this is definitely the right moment. We just had our Women's Day, and now we are going to have a World Sleep Day in this week. So we can't have a better day. So let us see.
So the topic that was given to me was menopause. Is it equal to sleep pause? That was an interesting topic. So before I go into it, we sleep specialists, we have a routine to give a talk about the sleep, basic stuff of the sleep. So as such, if you see, the sleep varies with age, and most of the time there is a lot of misconception that with age the sleep I mean the later elderly, there is a reduction of sleep need, and many times I've heard people saying that they need only 5 to 7 hours. No, that is not the same. They still need as much as possible. And now these are the different sleep stages. I'm sure everybody knows these parts. And just a minute, I'm not able to see. Sorry. Yeah, so you know there are different sleep stages. If you look at the autonomic activity, REM sleep is lot of alternating parasympathetic, sympathetic. NREM, it is more calm and quiet, and heart rate and all the breathing, everything is pretty good. So now when we look at the sleep stages, you know, what drives us. I'm hoping I'm audible. So if you see, there is the homeostatics. Whoa.
Sorry,
Homeostatic sleep.
Actually.
Okay. So homeostatic sleep drive is there, where that is the thing that gets accumulated. There are a lot of somnogens, most common one being adenosine, that will pile up during the day, and then it will slowly, gradually go down while you attain sleep. Okay, and there is the circadian rhythm. If you will see, this is the wake propensity, a small dip around the afternoon time when we feel the need for our siesta, and then it goes up back high at night, then it goes down again. So if we don't sleep around this area, okay, when it is dropping down, if we don't sleep at this area, we might miss it. Okay, now I'm sure you know much better than this, but still much better than me, but still I would like to cover this part. What is the role of estradiol and progesterone in sleep? There are so many places our female sex hormones work. So it can work in our ventrolateral preoptic nucleus, then it is in hypothalamus, then TMN, all these places it works. So overall, if you see, estrogen is promoting sleep. Okay, there is some mixed data on that as well, but progesterone, more or less GABAergic, anxiolytic, that is the effect. So hold that thought on. We'll go to this again. So over this, if you just overall look at no age or anything, most of the time, the insomnia, restless leg syndrome, global dissatisfaction, everything is more common among women. One of the main reason, you know it, lot of hormonal fluctuation. Evolution has not been kind on us. So when we look at it, menarche, you will see that, one second, I'm just coming out. I'm just going to stop sharing. There's a small issue with my, okay. So there is a delayed sleep phase, sleep fragmentation is there. And as the thing goes, we are slowly in the luteal phase. What is happening? Progesterone, sleep loves progesterone. When that is coming down gradually, we'll have awakenings. Trimester pregnancy, so many sleep disorders, all the discomfort, everything just adds on to the problem. But third trimester, apparently, there is worsening. That's the worst time. Okay. So sleep postpartum, again, sleep fragmentation, again, till the child is actually getting an adult pattern. So now look at menopause. In the definition, the permanent cessation of menstrual periods. It can be surgical, artificial, or natural. So endogenous, what is happening here? Okay, what is happening? Whatever be the gender, as the age progresses, the melatonin the secretion comes down. And again, there's the shift of the our sleep-wake cycle. Today, my tech is not cooperating with me. So sorry for that. So as age progresses, we do see a shift of our sleep-wake cycle towards earlier. So somebody who was sleeping around 10 to 11 and waking up around 6, there might be a gradual shift. Sometimes they might fall asleep around 8 to 9, wake up early in the morning, 3 a.m., can't bother anybody, toss and turn, have existential crisis and whatnot. So we were talking about, sleep-wake. So we were talking about the hormones, right? So estrogen, it is still mixed. progesterone, it is definitely sleep promoting. Sorry, there's a small typo. It is sleep wake promoting and sleep promoting. Sorry, wake promoting and sleep promoting, which is happening. Estrogen mixed, progesterone, definitely sleep promoting. Yes. How does it do that? Progesterone, it is improving the GABAergic receptor activity. So the benzodiazepine, it is like a kutti benzodiazepine. So it is already sedating and anxiolytic. So you can, think about that premenstrual worsening of the mood, irritability, when progesterone is not in the right levels, all these mood changes happen. Estrogen, yes, in high doses, yes, it is good in sleep, but in lower doses, it actually causes sleep disturbance. It is more wake promoting. Now, more than that, the thermoregulatory role of it, the effect on the noradrenaline and the serotonin, acetylcholine, all those again indirectly affect our sleep, anxiety, mood, everything. So if you look at menopause, there are so many changes in your sleep, not just insomnia, sleep apnea, restless leg syndrome, all those, so many things are happening. Okay, so sleep, there were so many studies, there are so many meta-analysis even looking at the prevalence. 40 to 69% of women are having sleep disturbances. And if you look at just insomnia, in perimenopausal women, some of the studies say even 61%, which is highest for any age group, any gender. And mind you, it never comes alone. It's one of the, it won't be just insomnia, just sleep apnea. Something or the other always be there. So we need to dig further and further to take care of it. So before we jump into insomnia, let us know what is the definition. So rather than going with an ICD classification, we have our own classification. Okay, so International Classification for Sleep Disorders. Right now, this is the third version. So if you remember, there was a time where we used to say that primary insomnia, secondary insomnia, psychophysiological insomnia, all those are gone. We are not trying to figure out which came first. There is insomnia, treat that as well as the associate things. So what is the criteria? When can a person say they have insomnia? Can I say insomnia when I have one night sleep disturbance, 2 night? We'll see. So what should happen? There should be sleep onset issues, there should be sleep maintenance issues, and waking up early and that decide. Mind you, waking up early, I will always think of, is it a depression? Now, because of the sleep disturbances, you should have any of these issues the next day. If this is not there, but the person is claiming that I'm having sleep disturbances, I would think more in the line of paradoxical insomnia. Okay. And this should happen despite adequate opportunity. The person is not going to bed for, it's not he or she is not sleeping for she is not in the bed for more than 6 hours. They are not getting enough opportunity to sleep at all. In that scenario, we cannot say it is insomnia. And the frequency, it should happen 3 times per week. Initially, we used to say it is chronic if it goes beyond 1 month itself. But now, studies show that we cannot name it now as a chronic. It is still acute till it crosses 3 months of it. Then we say it is chronic. So what are the usual etiological conditions, especially in menopause scenario? Okay, so age, as we mentioned before, there is a circadian rhythm changes. Menopausal symptoms, the vasomotor symptoms have been the strongest predictor for sleep disturbances. Bladder concern, ma'am was talking about that, right? Chronic pain, we all know once adulthood sets, the perpetual pain over back, over knees, all those things just come and mess up our sleep quality. Then chronic illnesses. Can anybody put it in the chat group? Which are the usual illnesses that can contribute to sleep disturbances? I was hoping we'll have an interactive session rather than me just, rambling about. Just 30 seconds, just put in your answers. We'll have an interactive part on this. Yes, I see a response. Arthritis, very good. Yes, arthritis mainly because of the pain. Any other illness as a nature call, bladder concerns, we already talked about that. Chronic illnesses, or let me be clearer, diagnosis that is usually associated with sleep issues. So COPD can cause, diabetes can cause, anemia can cause, all these things can go on. Yes, restless leg, perfect example, right? And So can anybody name a few medications that can cause insomnia? Again, another 30 seconds. Notorious to cause sleep. We are all giving it left and right. We see one blood report and we are dumping the patient these medications. And we, OHAs, okay? Medications, specific medications, that is so notorious, and it is always given at night. Starts with S, ends with N. Can anybody guess? Statins. Statins are notorious. Solicitin. Oh my God. Okay. So I'm talking about usual, the statins are very, very good guess, but the word I was looking for was statin. Okay. Many of the time we do see, pulmonologists giving theophylline, deriphyllin. That is again notorious to cause sleep issues. Beta blockers like propranolol. That can cause a lot of insomnia and weird dreams, vivid dreams. So yes, these most of the time they might be given for asthma and everything. So what are the psychosocial factors? Depression, almost 41% perimenopausal women have depression. Anxiety, no progesterone. Where is the anxiolytic effect? Substance use. Yes, maybe not very common in Indian scenarios, but the trend is on a higher, is in an increasing pattern, definitely. Alcohol, definitely many of them see that. Familial concern. Whatever it is, yes, we are still in 2025, but still the caregiver burden still falls a lot on the female population. Bereavement, slowly, this will be the age they might be losing their beloved ones and having to multitask finances, again, career concerns. Suddenly they are in a senior positions, but they have to handle other familial, all these commitments with only 24 hours in a day. Multitasking is not easy. And now the major role, suddenly there's an emptiness syndrome. Children are leaving the house, or the next phase even, grandparenthood. Suddenly they have to be, they're already struggling with their own health. Having to take care of a child is not an easy job. Having to take care, not getting enough sleep, adding on to that the sleep disturbances. Okay, so how can I screen? How can I screen? That's a very common situation. Should we screen all of them? So certain factors, if you can note down, or you don't have to maybe sit and ask all that, maybe incorporate them in your pro forma that you use in your clinic. That might actually go a long way to give a holistic role. Or you can even have different options for different patients. So let's say you can put a pamphlet. Do you feel you have sleep disturbances? You can have a pro forma separately for that. So we always believe in the 3 Ps. What is the predisposing factor? Has there been in previous depression of insomnia? Previous insomnia can only worsen during menopause. Obsessive traits, neuroticism, anxious personality, avoidant, dependent. We need to say any other hormonal changes, thyroid, very, very bad. And obviously our age-related changes. Now the predisposing factors, age-related, it's precipitating. So now age has happened, poor health, then the pain. We talked about all this stress, other sleep disorders, very commonly seen, sleep apnea, restless leg, hot flashes. Again, just a reminder, I'm repeating a few, there will be a few overlaps so that it is emphasized again and again. Then perpetuating factor, how they look at their sleep disorders. They might be lamenting all the time. Their mind might be making them worry about the sleep. I would not to say they are worrying, because it's not them doing it voluntarily. It is their brain that is making them worry about it. It is that thought is put in a loop again and again. And their sleep cognition is revolving around that. Oh, not what if I don't sleep tonight? Sleep related habit. I'll go to bed early so that I'll fall asleep early. Never helps anybody. Okay, negative. So, okay, I haven't slept properly, so tomorrow I will be irritable. And they tend to be irritable, hyperarousal. They are going to bed, that anxiety is setting in. What if I sleep tonight? What if I don't sleep tonight? So that agitated, hyper-excited mode will be there, which is not exactly conducive for sleep. Again, sleep hot flashes also happen. So, okay, I have found a few patients that yes, they might have potential sleep disturbances. What question can I use? Or you can ask, I don't have time for coming up with a complete pro forma for this. What else can I use? So this is such a simple women-centric insomnia scale. Okay. it is validated beautifully for 50 to 70. Perfect for us. 3 to 5 minutes. It's a self-rated. You don't have to apply it. Just put a pamphlet there. If the patients feel, maybe I want to check myself, they can, during the waiting time, they can do self-check. You can come up with your different languages, local languages. It might actually help them to recognize the situation. Now, is there a cutoff? As of now, no cutoff is there, but definitely the more the score, not so good, right? Yes. So how do we actually manage this? Is your role only to refer? Okay, definitely not. You are part of the screening. We don't want a gynecologist just to be part of, okay, you do this, you go there, go. No, you have way more role in this. Sorry, it's not OSA profile, insomnia profile. Definitely flyers in clinic, educating them with regards to the sleep and MST. For a long time, I even thought it was still HRT. Then I realized it is MST, right? In menopause, just a minute. Yeah. So if you'll see, there are different levels of evidence. The highest level of evidence came in this direction. And these are coming from meta-analysis by Dorsey. So definitely see if you are already focusing that on these, definitely you will see there will be a difference in your patient's sleep profile. So before and after is something that you can look at. Now, so, okay, more than MST, what can be done? Okay, so again, this is more of an FDA approved approach. Most commonly, what we FDA is recommending is esopiclone, 3 milligram. Esopiclone, more than zolpidem, the advantage is a longer lasting T-half. So by doing that, you're actually improving the sleep onset as well as sleep maintenance. In women, perimenopausal women, more than sleep latent onset issues, it will be awakening. In between. So esopiclone has a superior role than zolpidem. Ramelteon, the name is, what is Ramelteon? It has first initially came as an antidepressant and acting on melatonin, but now, sorry, it did not have much role as antidepressant, but definitely for sleep and sedative, yes, that is something. And now suvorexant. So all these are promoting sleep, right? The zolpidem, GAB, and alprazolam, everything, they're promoting sleep. Suvorexant is a medicine that is reducing wakefulness. It is attacking on the orexin. So what about our benzodiazepines? We are all, we see so many prescriptions with alprazolam, lorazepam, nitrazepam, all those things. So what happened to them? Yes, in India, they are still very well used. Sadly, they are not FDA approved. And especially if, let us say, you are prescribing to a patient who is going abroad. Most of the time, the list of the medication that cannot be taken there unless and until you have a prescription. Most of the time, benzodiazepines will be part of that. And if, let us say, you are practicing telemedication, only clonazepam can be given as per the rules. Okay. Antidepressant. Yes, there is comorbid depression. Escitalopram, mirtazapine has good evidence. More than that, from an VMS point of view, duloxetine has more role in the reducing of the hot flashes. Antipsychotics, we do see a lot of people giving quetiapine or olanzapine. To be honest, there have been studies saying that it does more harm than help. So I would suggest to avoid that. Gabapentin, yes. With VMS, yes. So can anybody tell me some herbal preparations that have been tried in sleep? Again, back to the chat. 30 seconds. Oops. Any herbal preparation that you've heard of? Milk with turmeric powder, pepper, very good, very good. Chamomile, peppermint, very good. Yes, so chamomile, then chamomile, lavender, and valerian, all these have evidence-based attached to it. Yoga, yes. Hypnosis, okay. CBT, we look at it definitely more. Okay, now acupuncture, sorry, not really. Okay, right. So what is CBT? So here it is an incorporation of all the non-pharmacological intervention, working on your sleep hygiene. I'm sure I don't have to go through it. Everybody knows what should be done for sleep hygiene. But what is stimulus control? Using bedroom only to sleep. In the era of work from home, most of the time you see the office area is inside the bed, inside the bedroom. And sometimes there'll be people working on your bed. We don't want that to happen. When you're not falling asleep, get out of the bedroom. Not just the bed, out of the bedroom. Why are we doing this? We are bringing that association that bed is a place for exclusively sleeping, not for reading, not for tossing and turning, not, and we want to detach that it is from the fact that it's an anxiety triggering place. Sleep restriction. So what we do is, let's say a person is sleeping only 4 hours in between. So we are going to reduce the time that they're sleeping gradually. So by that, we are actually improving their sleep efficiency. Okay. So of the time that they're in bed, very lesser time, they'll be actually tossing and turning, improving their sleep efficiency. And with that, we gradually advance the time that they're in bed, improving their overall sleep efficiency. Relaxation techniques, the evidence-based ones are guided imagery, guided imagery, progressive muscle relaxation, then deep breathing exercises, and all these white noise, all those things are worth trying. So what are the cognitions that can be off? What is happening? What is the cognitive part of the CBT? So it is an ABC. So there will be some anticipatory issues, how they look at it and the consequence of it. So they're already, as they go to bed, they'll be worried. Oh God, I'm not going to sleep. I'm going to be frustrated. What is going to happen tomorrow? I'm going to be sad again. Then physiology, is there any pain? Now that is also going to worsen my sleep. So how are they going to worry about? How are they going to worry? They'll want to worry. Let us say we are losing our sleep for a Netflix binge. We won't get worried about it. But let us say we don't sleep. We are giving more negative tonation to that whole point, right? If it was a party, we will not be worried about it. So how you look at it? It's okay, just another day. How to convert to that? How to reconstruct that? That is where we're going to happen. I'm going to be tired tomorrow. I'm going to be irritable. All those things. I should sleep for 8 hours. Misattribution. So let's say next day I am tired. I know it is because I didn't sleep. Maybe you were just dehydrated, but no, it is only because of my sleep. So what do? They will tend to spend more time and they will nap a lot. So many weird. So, okay, I'll exercise a lot so that I'll feel tired by the end of the time. And when they exercise too close to the bedtime, they'll feel actually more excited. Adrenergic thing drive will be there, will not sleep at all. So the consequence will be this whole vicious cycle. So how we can break it? That is what's going to happen in CBT. So can anybody tell me the most commonly used hypnotics in a Indian household? Indian household, what are the nuske or, household hacks that people usually use to make sleep? Reflect. What do many people say, try this, it'll help you sleep. Anybody? Okay. So I think I'll go ahead. Sorry, I see somebody has mentioned something. Keep cotton on your khadi khas. Yes, khas, many people do say. Antihistamine. So many people use antihistamines just to sleep. I know I will sleep with this. So cough syrup, levocetirizine or cetirizine, Avil, people try doing all that. Then many people, yes, the khaskhas, exactly, Benadryl. People use khaskhas. They will put it in milk and drink it. Many people do that. And alcohol, yes, self-medication is here. It is real. Okay, sometimes it might come from Ayurvedic preparations also. They have very high, some of them, they even have very 8% and all alcohol if you check it, right? And this is a new thing. Many people I've heard, they will smell it and then they'll rub it behind the ears. They say, that makes me feel relaxed, and look at it. As far as I know, menthol is the active preparation. So far, I feel there is no harm from it. I don't know if there is any help, but as far as I know, there's no abuse potential to it. Milk, that is something which is evidence-based. Milk, anything that has high tryptophan. If you want to go fancy, kiwi, cherry, yes. Banana, yes, it can help improve your serotonin and tryptophan. If you want to be really scientific, milk got from the cow at night, which will have its own melatonin. You can go in that line as well. So just to summarize, I would like to talk about... So here, just to summarize the other sleep disorders also, if somebody is having So if there is recent stress, psychiatric problem, the psychiatric evaluation, vasomotor, let's attack it in that line. If it is the circadian rhythm, then look in that line. So you might want to start them considering an advanced sleep phase. You might actually tell them to watch TV or sunlight or be exposed to bright light late in the evening, unlike the other people. Abnormal behaviors observed, parasomnias. Usually parasomnias will be, NREM parasomnias will be more in the childhood, where they tend to cry or sleep, all those in the night, and they might be completely amnestic. In REM behavioral disorder, usually it might be a precursor of Parkinson. They might act out their dreams, mostly in men, but definitely not. It's not like it's not there in women. So try looking at that. Snoring, apnea, we already had a session on that. Look into that. Any strange sensation, RLS. Severe daytime, look into narcolepsy. Usually not first onset during so late in menopause, but again, medicine is all about exceptions. So that is the summary. So that you don't miss on anything. Now, how long do we give the medication? Again, it's a question. Is it till the end of menopause, lifelong? What do the guidelines say? Any idea? How long do we give the medication? You must have seen people taking benzodiazepines for 20 years. When did you start? Oh, I had started it when I lost my husband. When was that? 15 years ago. I've been on this. Gradually, the dose has been going up because it's not, I've got tolerance towards it. So how long should we give? Any idea? Around 2 months. Okay. Any other answer? This is the last slide, so I'll be done soon. As long as the patient needs. So as per AASM, American Association of Sleep Medicine, the drug of choice, or rather the procedure of choice, would be CBT, and or the medication should be as temporary as possible if it is primary insomnia. If not, then treat the other things and then go by it. So as long as the patient, it has to be customized. Now, so I really want to talk about this. So what happens if the insomnia is untreated? It is an obvious answer. Obviously, quality of life is going to be affected. But to be honest, there is not much data on this. So I feel this is a major gap or lacunae in literature that maybe this society can fill on. Okay. Now, we've been talking about all the menopause and its effect on sleep and causing insomnia. Why not the other way? What is the effect of primary insomnia, which has happened before, and how does that cause any effect on menopause? Is there any worsening or anything, or early, any change in that? No data on that. So something maybe, we could do a lot of retrospective studies. So I brought these reflection points to show the lacunae in the gap in the literature, something that we need to work on. So maybe this could be a platform to make you think, okay, I can do this. This is doable. Maybe we can work out with a methodology or a protocol, something like that. So these are my references. Thank you.
Thank you, ma'am. It was a very informative and interactive session.
Thank you for interacting.
Can I ask a question?
Yes, ma'am.
Yes. Nilima, I think that was quite an exhaustive coverage. But my query is, what about the dreams which are coming early hours and disturbing the sleep? What do you prescribe for them?
Yes. So, 1 second. Okay. So,
because sometimes the dreams are like you are lost in somewhere. You want to go out of some place, you can't find the way out, and like that. Those sorts of dreams, when they are coming, you cannot even get up, you cannot go to deep sleep even.
Exactly. So what is happening is, or most of the time, how as a sleep specialist we look at dreams is like, what is the content? Is it too negative or emotionally charged? Then I would like to address the anxiety part. That means when we are sleeping, the noradrenergic system is hyper. Okay, so that usually determines the content of the dreams. Now, second thing, how to manage. Usually nightmares as such, we don't prescribe medication. We can reduce the REM sleep by giving benzodiazepines or medication. The GABAergic medications do reduce the REM sleep. However, usually the treatment for nightmares would be prazosin, but we only use it in PTSD, not in usual dream scenarios. A nightmare disorder as such, we say if you get a nightmare more than once a week. So, but we rarely give treatment. Relaxation techniques before you go to bed, that is something we approach.
CBT?
CBT, definitely. And
CBT
relaxation techniques just before you go to bed. That can go a long way. So that you are reducing you relax and unwind.
Okay. Thank you. I think that was a very nice coverage. Chairpersons can comment any
Thank you.
question.
We request chairpersons to share their thoughts.
It was an amazing, sorry, excuse me, my throat is very bad. Amazing presentation, and I learned a lot. I just wonder how long to give pre-GABA. Do you have any time limit for that? You are on mute.
The sooner we can stop, the better. But usually pre-GABA alone for sleep is rarely given. It might usually be given in line for some other neurological issues.
After surgery or something, right?
Yes.
After surgery.
Yes. But if it is something like that, then we can stop as soon as possible. That would be, and I would like to switch to melatonin. We can even try that. I'm so sorry for this disturbance. I thought I had locked my door. Sorry. So melatonin, what we usually do is, if we cannot stop a medication, switch to something. And right now we do get a lot of melatonin sustained release preparations, which is wonderful, because initially melatonin issues, it can be given only for sleep onset. So just a push into sleep. But the sustained release preparations can actually help in sleep maintenance as well. So if we can switch into that, that would be great. So duration, as soon as possible, if you can reduce GABAergic medication, that's better, because the propensity of damage for and causing dementia, cognitive deficits is very, very high. So the sooner, the better. That's the answer for me.
What about levocetsin? Any anti-allergens?
Sorry?
What about levocetsin? Any anti-allergens?
No. That's why many people use it a lot. They self-medication, mostly because they're all OTCs and easily available, no restriction. People are there who drink cold cough syrup. You know, that is edging towards a dependence pattern rather than a more of a helpful pattern.
Thank you.
Thank you, ma'am. We now request Uma ma'am to introduce our next speaker.
It's my pleasure to introduce Mr. Karthik Rao, who works in Jogo Health, is the Director of Clinical Operations. So he used to work as a consultant in IIT Madras for the development and dissemination of a standing wheelchair. Worked as a HOD and Senior Manager in Spastic Society of Tamil Nadu, proprietor of Shrishti Child Development Center in Chennai. He is a certified OTA GO Otago Fall Prevention Program certified therapist, advanced stroke rehabilitation based on Bobath concept, and also is a certified access auditor. And his achievements are one of the course writers for early childhood special education enabling inclusion, cerebral palsy, conducted by IGNOU, New Delhi, and co-author of Manual on Basic Developmental Therapy. He's also published titled How to Improve Attention in Children with Special Needs. So he is a specialist in sensory integration. He's a member of Indian Association of Physiotherapists and member of Rehab Council of India. And also is a secretary of Aquatic Therapy Network of India. I welcome Mr. Karthik Rao to deliver his lecture.
Thank you, ma'am. Thank you for a warm introduction. I hope I'm audible.
Yes.
Yes, sir, you're audible, sir.
Yeah. So let me share my screen. And at the outset, I would like to thank the organizers for this opportunity for presenting about fall prevention. Just like ma'am was talking about aquatic therapy as one of the models, With respect to fall prevention, we see that water is a very good medium because the ground reaction force is very less in water. And we see that that makes a major role. And many times the fall doesn't give us time to react. And that is where we get that when we train fall prevention in a swimming pool, we actually get that time as well. So I'm basically a physiotherapist with 22 years of experience. So let me take you into and have a discussion on this fall prevention. I would like to congratulate Dr. Nilima for a wonderful presentation. It was very interactive as well. Is my slide moving?
Yes.
Yeah, great. So when we look into the fall, so one of the things, like, I just would like to ask the audience, if I fall because I have a dizziness, okay, will that count as a fall or not? If I have let's say I have a heart attack or something, if a person falls because of that and they are losing balance, so will that come as a fall or not? Yes or no?
Yes.
And to make it easy for the audience, I would just request you all to just type Y or N in the chat box. We just stick on to one alphabet, make it more easy and inclusive.
Dizziness becomes one of the, I think, causes of the falls also. Important causes of the falls if they are because of any comorbidity.
Yes, yes, doctor. So what we're looking at is we are not looking at something which is as an organic cause. We are looking at something fall which can be part of a normal aging process. And so to take this further, a fall is defined as an event which results in a person coming to rest inadvertently to the ground, which means like I'm not trying to come to the ground. It's out of my control. I reach the ground or at a lower level. And it's the second leading cause of unintentional injury. And adults more than 60 years suffer the greatest number of fatal falls. And that brings us to something which is very prevalent, that 1 out of 3 people fall each year under the age of 65. But as the age progresses, the frequency of fall increases very much. Yeah. So we have the fall results in a very serious injury. And out of 1 out of 5 falls results in a serious injury. And is number 1 reason for death more than 65 years old. 95% of falls result in hip fractures. And if somebody has fallen once, the risk of falling again increases. It doubles the chances of falling again. So let's quickly look at one particular, I just took that out from the video from the internet. And this is a CCTV footage of what has actually happened in a rehabilitation center in UK, resulting in a fall. Now, when you look at this fall, can somebody tell me, like, what is, how can this fall would have been prevented? How can we prevent this fall?
This fall?
How could have this fall been prevented? An elderly person is trying to sit on a chair.
Louder, sir, please. Little bit louder.
Okay, am I audible? Is it too low for you?
Yeah, yes, sir.
Yeah.
Maybe by locking the. Can I
wheels of the chair.
answer?
Yeah, locking the wheelchair because that wheelchair had wheels and he was sitting. Yeah, that is one way of doing it. And when we look at the fall, then is there any other way? Anything else that could have been done to ensure that this elderly wouldn't have fallen?
Strengthening of the muscles.
Yes.
Movements of the joints.
Right. So so if I look at it from a different perspective, it could be because the person was alone, number 1.
Okay.
He was trying to sit, and when he was trying to sit, when the moment the chair moved away, he was not able to regain his balance. Okay. Not everybody is trying to sit, and when the chair moves, not everybody would fall. So there are some intrinsic factors and there are some extrinsic factors. The extrinsic factors is the chair moving away. The chair has wheels, there is no lock there for the wheelchair. But the intrinsic factors, there is a muscle weakness. And when we talk from a type of muscle contraction, this is more of an eccentric muscle contraction, which has to control the descent, control the movement of the person towards the chair. Now that is affected. And the person was then, and he was totally into flexion. Because he was holding on to some chair in front, that also played a role. Okay. He was holding on to the chair and table in front, and that plays a role in because that was promoting a lot of bending and flexion in his body. And if he was upright and trying to sit, and if the chair had moved, he would have been able to get up easily. So it's a combination of multiple factors. So if I look at the phases of falling, the first phase is that when the person is trying to do something and the body weight is shifting beyond the base of support. The base of support is only the feet right now and the point of contact with the arms. And there is a change in the base of support. Then there's a failure of system. He has muscle weakness. This is more intrinsic. The second point is more intrinsic. He didn't realize he was going to fall. He couldn't recruit his muscle that could prevent the fall. There's muscle weakness. So these are all the failure of the innate body mechanisms that prevent us fall. And the third is that the impact of the body on the environment. Now, if he is landing on something which is a soft mattress, that will not result in fracture. Okay, or he's sitting on the chair which has a lock, then that wouldn't have resulted in the fall. So there are a lot of things that we are looking at. The one is the initiation of movement, second is the intrinsic factors, third is the environmental factors, and the point of contact. So everything can have an impact on the final fall prevention. So we use something called as a steady questionnaire, a stay independent questionnaire. So the entire fall program that we are following at the Otago is based on CDC guidelines in steady. So this is basically a questionnaire or a screening kind of questions which we ask the patients to do. And any score more than 4 means that they need to be investigated further. What could be the reason of fall? It could be organic, it could be aging process, it could be because of medications, it could be because of poor muscle weakness, or it could be because of poor vision. There are a lot of factors that can contribute towards a fall. So once the screening has been done and we've identified that this person has a weakness, then we look at 3 main tests. Okay, so let me just quickly show this test. The first test is the 4-stage balance test.
Getting up, walking, simple.
4-stage balance test assesses static balance, which is an important part of postural stability. To perform the test, you only need a stopwatch. Tell your patient that you will show her 4 positions and would like her to try and stand in each position for 10 seconds. She can hold her arms out or move her body to keep her balance, but should not move her feet. For each position,
so we ask the patient to assume 4 different positions. So these are the 4 different positions. First is they stand with their feet together. The next would be 1 foot slightly ahead of the other. The third is a tandem position. And the fourth one is a single leg standing. And if the patient is able to do all of that, that means they have a very good balance. And if not, then we look into other aspects as well. So needless to say, because these tests have a high risk of fall. So the person who's doing that examination needs to be with them, make sure that the environment is safe and the help is at hand. The second test is the 30-second chair stand test.
When you say go, she should stand up all the way and then sit back down, doing this as quickly as she can until you say stop. Arms should remain folded across her chest throughout the test. Stand close enough so that you can catch the patient if she loses her balance. If the patient gets tired, she may rest, but let the time keep going. If she cannot stand even once, the test score is 0. Not being able to stand up from a chair without using one's arms to push up indicates a high risk for falls. Record the number of times the patient stood up in 30 seconds.
We're noting down the number of times the person is able to do sit to stand, and these are the normative data. And when we look at the age and compare with what is the average, and people who have less than average have a higher risk of fall. The third test is the timed up and go test.
Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path.
So we check what is the duration of time the person is able to get back to the chair after getting up. So it's a standard distance of 8 meters. And they just go and touch it and then come back. So any person who takes more than 12 seconds to come back has a higher risk of fall. So all these things are factored in. So once you have the fall history, the medical conditions which can impact, let me just zoom it a bit. Problem areas with the heart rate, cognitive impairment, or it could be medications, it could be the strength. We looked at these 3 tests. You can look at vision, because sometimes when you don't see well enough, there's a higher risk of stumbling across objects, and that can lead to a fall. And then postural hypotension is another condition which can lead to dizziness and fall. So all of those are considered during the assessment for fall. And once the person is able, we have a clear picture of what is the patient, then we look at this algorithm, which categorizes patient with fall risk. We got a low risk, a moderate risk, and a high risk. So once we identify based on this algorithm, what is the patient's strength, is there a history of fall, how many falls he had, did the fall result in injury, and then what are the other factors, organic issues, medical comorbidities, everything will categorize and help with that will help us to categorize the patient as low risk, moderate risk, and high risk of fall. And once we categorize them, then the treatment about the customized fall prevention program would start, which will help us to give a customized exercise program for the patient, and also look at other aspects like maybe there's a home safety that needs to be considered. There should be a lighting at home that needs to be considered. We can look at the rugs in the home. We can look at slippery bathrooms or wet bathrooms. So all of that needs to be considered when we're looking at a complete fall prevention program. So the Otago program primarily focuses on 3 areas, which is strength training, balance, and then walking. I have a quick question to the audience. We looked at 3 tests. One is the 30-second sit to stand test. One is the 4-stage balance. And the third one is the timed up and go. Right? So which one is the right test for strength out of these 3? I would like to look for your responses in the chat box. We had looked at 3 tests. Which test is testing the strength of the person? Is it the 30-second sit to stand chair test? Is it the timed up and go test? Or is it the 4-stage test? I get 1 response, sit to stand, 4-stage test. Just wait for a couple more responses. Standing and walking, which is your tuck test, I guess. Right. So the strength testing is the sit to stand, 30 seconds sit to stand, number of times they're able to sit to stand. That's what we're checking. So that is the test for strength. Okay. And the 4-stage is for balance. The timed up and go is for walking. So we're looking at each of these as a standardized measure. And that helps us to understand where we need to target as part of the training. So these are some exercises as part of the Otago program, and you can always have the liberty to customize it according to the patient. So we actually categorize the patient as ABCD based on their risk profile. And let's say somebody, for example, if I'm looking at this, the second, the middle one in the top, where sit to stand is there. Now we can customize this by having a table in front and asking the person to hold the table and stand up, or they can be sitting and in facing the window and they can hold on to the window grill and then stand up. So if the balance is very poor or they have a very high risk of fall, then we can start with that and gradually move them from high risk to moderate risk to low risk. And that would be the progression of the patient's ability of increase in balance. So in addition to this, we also need to look at fall prevention is not just about exercises. It's also about having the architectural support in terms of hand railings, grab bars in restrooms, removing clutter. So these are the environmental modifications, non-slip mats in the restrooms, making items accessible, not asking them to bend and pick up something. It can be kept at a higher level so they don't have to bend. So if you bend, the risk of falling increases. And if they have dizziness, then again, that increases the chance of falling. Improve lighting, wear well-fitting shoes when they're going, because if the shoe is too big, too small, then that can also lead to falls. Review medications with the doctors, getting your vision checked, and also a regular exercise. So everything has to be looked as a continuum to get the maximum out of the fall prevention program. And one of the most common thing that happens, somebody has a fall, then there's a natural fear that happens with the elderly, is that if I go out, I will fall. And because if I fall, I'm going to hurt myself. So let me not go out. Let me stay indoors. Let me stay at home. Okay. So, and let me not climb stairs. Okay. So they're concerned about the activity so much that they restrict themselves. And so there is once a fall happens, so it's a vicious cycle. Once a fall happens, there's a loss of balance and confidence. The patient has a fear of fall, then they themselves restrict. If I restrict myself from climbing stairs or walking outdoors, then what is going to happen? I'm not going to use my muscles and joints and anything which is going to stay there without being challenged is going to lower the performance, right? So it's like kind of rusting, anything which is not rusting a metal. So very similar to that, if the muscle is not used, the muscle becomes weaker, then my balance is going to get affected. So that changes the way I'm sitting, standing. I can put on more weight. Obesity can be a factor, and that increases the risk of falling. So the chance of falling again increases more because the patient or the person has tried to restrict themselves from trying out all those things. Okay, so the solution is to make sure that they do it under supervision. If you're not confident, they can go along with somebody. Many times it's not practically possible, but that is where we need to educate, or the children, adult children should be able to spend time with the elderly parents to make sure that they are active. So we need to work on all the areas. So the solution with fall prevention is not to restrict, not to rest, but to be active and engage in a lot of other activities. So what we have with as part of a program, we call it as Good Life. So it's just a fall prevention program where we have it's almost a 6 months program that we do. The original Otago program is for 52 weeks, which is 1 year. And we always look at, so what we have done is, and almost every country has a standard fall prevention program, because many times it is insurance driven, it is the state subject. Whereas in India, it is not a state subject, it is an individual subject, because patients pay out of their pocket. And so we do not have a government level or a state funded fall prevention program, because if it is insurance, they are more concerned about the claims that they get because of hip fracture, and they want to minimize that, and they would like to work something on prevention, which is almost 1/20th of the cost of hip surgery, right? So that liberty or that facility is not there in India currently. So what we have is a fall prevention program that addresses prevention. So it's a wellness program. It means that everybody needs to do it. Anybody more than 60 would benefit from it, and the cost of not getting into the fall prevention program is way higher, and not just for the person or the patient who had a fall, but also for the entire family. Right. So with this, I would like to conclude my presentation.
Madam, Sumitra Madam has raised hand. Any doubts, Madam? Sumitra, madam.
Yeah, so can I answer a few questions that I can see on the chat box?
Yes. Yes, sir.
Yeah. So is weight training, weight and mass for muscle strengthening or walking will suffice? So the concept of muscle strength being maintained is based on resistance. Okay, so the weight is going to give resistance, and when the muscle works against resistance, the muscle power increases. And if we do something at the same level, the muscle power will come down. It will not be maintained. Okay, so weight training is important and so there are two forms of resistance. One resistance can be weight, the other resistance can be gravity, because when we do things against gravity, our own body becomes a resistance, right? So like climbing stairs is a good exercise. It's a resisted exercise for the lower limbs, right? So stair climbing can be a good example where if you don't want to use a weight, but you want to strengthen your lower limbs, stair climbing, squat to stand are good examples of weight, resistance based training without weights. So wherever it is not possible, then weights can be added. We can gradually increase from 1 kilogram to 2 to 3, depending on the person's muscle strength and ability. I can share the details of fall prevention program to the audience later on. I guess I'm not sure because I didn't want this to be a pitch. So that's why I've not done it, but I can probably share that with the organizers so that anybody who's interested can get the information.
Thank you,
actually, last year, Dr. Karthik, that was a wonderful presentation. And that's why I stayed here, because I really wanted to listen to you. Because last year, since 1 year, I have been very passionate about fall prevention, as the osteoporosis doesn't kill you. It's the fractures which kill you. And the fractures are happening because of the falls. So they can be, like you said, the home circumstances that is there. But what about our roads? What about our parks? They are not even made for the elderly people at all. They are not looking into the needs of those above 60 or 65 years. They are not giving them places to work out. They are not giving places them to socialize even. So I think lots of work has to be done. But I think your center is wonderful work. We don't have any centers like this. I wish there were some centers in our part of the country also, which deals specifically with the fall prevention, because it's a very, very important issue. And I really congratulate the organizers for taking this topic. That is the hit, because we don't have to talk about treating osteoporosis. Very few people in reality can take those drugs for a long time. So what we have to do is to change them so that their falls are prevented and they don't have the fractures. Simple things can be done, like you showed that video about chair being sleeping. So because of proprioception is also not good. So all these things are there.
Yeah, thank you.
Thank you, ma'am. We request the chairpersons to share few insights.
Then, okay, then I think we can bring this program, this session to an end,
Yes, ma'am. Now we come to the end of the first session. We now move on to the quiz for the delegates.
Okay, ma'am.
So we have the much awaited quiz for delegates. Yeah. Sahiti, can you host? Yeah.
First question. Sandhya ma'am, can you please read the question?
First question, how can regular physical activity positively impact mental health during Geripause? Option A, by eliminating the need for therapy, by reducing stress and improving mood through endorphin release. Option C is by suppressing emotional expression. Option D is by completely reversing hormonal changes.
Here is the question.
Last 5 seconds. Time up. Second question.
The second question, regular physical activity can help prevent falls by option A, improving strength and balance. Option B, increasing body weight. Option C, slowing down reaction time. Option D, encouraging sedentary behavior.
Last 5 seconds. Time up. Third question.
Which of the following is a common effect of a decreased metabolic rate during Geripause? Option A, rapid weight loss. Option B, increased energy levels. Option C, unexplained weight gain. Option D, improved digestive efficacy.
मंडे लास्ट है शायद कल जाना फिर उसके बाद 3 दिन की छुट्टी होगी फिर मंडे लास्ट शायद होगा
Last 5 seconds. Time up. Fourth question.
Fourth question, what is the minimum duration for sleep disturbances to be classified as chronic insomnia according to ICSD-3? Option A, 1 month. Option B, 2 months. Option 3, 3 months. And option D, 6 months.
3 months.
उसने पहले ध्यान दिया था डांस क्लास सॉरी म्यूजिक क्लास
Last 5 seconds.
फोटो में दिया हाँ 3:30 से 4:30
Time up.
तो फिर
Fifth question.
कहता नहीं जाना टेनिस
Which of the following is a common symptom associated with sleep disturbances in menopausal women? Option A, hot flashes. Option B, increased appetite. Option C, weight loss. Option D, increased energy levels.
Five more seconds. Time up.
Thank you, Sakti and Sandhya.
Thank you, ma'am. We now move on to the second session, which is going to be a panel. I welcome the chairpersons for this session, Dr. T.P. Kanagu, ma'am, who is Director of KM Hospitals and IVF Center, Chennai. Her madam has done her MBBS and DGO from Stanley Medical College, and she has been the best outgoing student in MBBS and received a gold medalist in her DGO period, and has done her MD from Madras Medical College. And madam was an assistant professor in OG at Government RSRM Hospital, IOG MMC. And she has been member of ASRM, ESHRE, ISGE, IAG, FOXY, OXY, ISR. Madam's areas of interest are endoscopy, ART, and high-risk obstetrics. We welcome you, ma'am. I welcome the next chairperson, Dr. Meena Mahalingam, ma'am, Associate Professor in Obstetrics and Gynecology, Institute of Social Obstetrics and Government KGH for Women and Children Hospital. Madam is the Secretary of OXY and Co-Chair of Urogynec Committee OXY, and she is a member of Urogynec Subcommittee OXY. Madam has a special training in urogynecology, microsurgery, and endoscopy, and been an instructor for basic newborn care and resuscitation program under IAP. She has 23 years of experience in tertiary care teaching institute and been a master EMONC and faculty and organizing member in national and international conferences. And madam has been member of FOXY, OXY, and CMS, IMS, AT, and RCOG, and published several articles. And madam has received a scholarship from IUGA for attending IUGA conference in Italy, and received a Best Doctor Award in 2024. We welcome you, ma'am. I now request the chairpersons to introduce the moderator and panelist.
Yeah, good evening, everybody, and thanks for the nice introduction. Our moderator is going to be Professor Vijaya Kutan, who has done her MBBS, MD, FMAs, and PG degree in aesthetic medicine and acne. She did her MBBS from JIPMA and her MD also from JIPMA, and has a vast teaching experience for past 25 years, published many research papers. She is trained in laparoscopy, hysteroscopy, and robotic surgery also, pain, palliative medicine, and many others, obstetric ultrasound included. Attended many conferences and made life very interesting. She is now affiliated to SSS MCRI, Chennai, and her designation there is now HOD and Professor SSM CRI. Her special interests are ultrasound, imaging, minimal invasive surgery, high risk pregnancy, and critical care, and also surgical gynecological oncology. I request her to be the moderator of the session. Welcome, madam. And as far as our panelists go, three of them we have already met. Dr. Balakumari, Dr. Leena, and Mr. Karthik Rao. Can Meena introduce Dr. Vijay Lakshmi, please?
Yes, madam.
Yeah.
Vijay Lakshmi madam is professor and HOD at Chengalpet Medical College, and she's done her UG in Stanley Medical College, PG at KMC Manipal, Karnataka. Has vast experience for UG PG teaching. Has been mentoring students and PhD scholars. Past president IMA Velachery branch, executive member OXY, life member Indian Menopause Society and ISAR. Her area of interest is high risk obstetrics, adolescent gynecology, fertility, gynec endoscopy. She is invited speaker and chairperson at conferences and workshops. Over to you, chairpersons. Over to the moderator for conducting the panel on Geripause.
At the outset, thank you.
Yeah, madam. Yeah.
Meena madam at Chettinad. I work at Chettinad, not Chengalpet.
Sorry, madam. Chettinad. Sorry. I came from Chengalpet, so sorry,
I
madam.
understand.
Chettinad Medical College, yeah.
Thank
Just joined Chengalpet recently. Sorry, madam.
Congratulations, madam.
Yeah, thank you. Over to you, Vijaya ma'am, for taking over the panel on Geripause challenges and solutions.
Good evening, respected colleagues. I am thankful for the opportunity to participate in this session, Geripause challenges and solutions, a panel discussion as a moderator. Geripause, a topic less heard and less known, but a topic relevant certainly as we ladies. It is the future of all of us. As a women, as the demographics change to increasing life expectancy. Good evening once again. So I wish to introduce a distinguished panelist. We have already introduced Dr. Balakumari, past president, Velachery IMA, Dr. Karthik R. Rao, Director, Clinical Operations, Jogo Health Private Limited, Dr. Nilima, Psychiatrist and Sleep Specialist, and Dr. Vijay Lakshmi, Professor HOD OG Chettinad Hospital. So to start with, we have 4 cases for discussion. So we have a 65-year-old lady who's undergone a vaginal hysterectomy for prolapse. A decade ago, complaints of sleep disturbances, awaking in the night and not able to fall asleep later. History of hot flashes as well. She has tried some conservative measures and she's quite tired in the daytime. What solution can we offer her?
I'm guessing it's for me.
Yes, madam.
Yes. Yeah.
Dr. Nilima.
Yes. So this is a very common scenario that we come across. Okay. So 1 second. Yeah. So one thing is 65-year-old lady. So first and foremost, a detailed history. Okay. And it has to start from rather than what solution, I would like to analyze the problem first. Definitely, I want to take a detailed history And it will not only involve the comorbids, the medications, her profile, obesity factor, all that. I will look at her nightly routine as well. What time is she having her dinner? What any late screen use, or what is her bedroom? How her bedroom is? Whether it is a sleep conducive environment, lot of clutter. Whether she belongs to urban setup where there will be a lot of noise and light pollution. All those kuti factors you will have to consider. Pains. Is there something that is obstructing your pain? Are you taking a lot of time to toss and turn, finding the right position? Is that a challenge in itself? Any restless leg syndrome? I will ask for that. So many women are anemic. That itself can trigger that. Any thyroid comorbidity? I will look into that. And following that, I will see, okay, how long does it take her to fall asleep? Okay, this is the time. And what do you do in the bed? What is happening? Do you, again, I don't want to disturb anybody. I'll take my phone so that nobody else is disturbed. Again, bright light, blue wavelength, messing up your circadian rhythm. Like second thing, let us say you're not taking the phone. What's happening in your brain? Thoughts. Oh God, I have not done that. I should do that. I have to worry about somebody else. Is your brain putting that your mind in a hyper agitated, hyper excited mode? Is your mind not shutting off? I would like to look into that. Okay. Or is the worry about the sleep? Most of the time they will say, I can see my husband snoring and sleeping well. Okay. That snoring itself is bothering my sleep. So I will even look into, is your husband having sleep apnea? I will have to assess that as well. So anyway, from there, are you having any snoring? Do you wake up, you finally somehow you fell asleep, and because of your snoring, you woke up because of the choking sensation. Nocturia. So many factors can cause nocturia. Diabetes, medication. Some of the medication cause so much of dryness of mouth. So you need to take a lot of water. Does that happen? Sleep apnea makes your mouth dry and you need more water. All those things till morning, and even after that, any morning sunlight. I'll ask all of this, and then I will see what can be done with that. Daytime fatigue. Yes, so sleep quantity is affected, sleep quality is affected. All these things I will have to look into. What medications do go? Definitely, I will look into that. What solution? After assessing all this, I will break it down. What is happening? What all, it is never one thing causing one. It is always a multi-dimensional thing converging towards sleep disturbances. All those factors have to be looked into. Is she a person who has neuroticism, worrying about things? Some people say, I know my mind, if something is solved, my mind goes and looks for things to worry about. It's not me. I don't want to worry about it. But my mind is actively looking out. So, okay, if something happened to the parrot next home, I will start worrying about that. It's sick, I will worry about the dog. So something or the other. So tackling that. So definitely, if the obesity factor is there, a dietitian consult, definitely. Pain, ortho, multidisciplinary approach is needed. And the common thing that I always ask, how do you relax? Most of the time answer is, I don't have a relaxation techniques. What do you do for your joy? Then they give me a list of their chores. I'm like, no, that is not what I'm asking for. I'm not asking about your duties and responsibilities. What do you do for yourself? In Indian scenario, self-care is so neglected. We have been conditioned to think that no, self-care is being selfish. So that is something I really want them to focus on. Finding themselves to something they enjoy. In the past 24 hours, what have you done for yourself? Most of the time, answer is zero. Focusing on that. Are you burnt out? All those things, definitely I would like to ask. And after that, what medications? I will definitely look at other possibilities. If there is anxiety, I might prefer if there is anxiety, I might prefer escitalopram because it has least interactions and not much of a gastric issue, reflux issues and all. So I might prefer that. Benzodiazepines, I might not be very keen on giving that. So right now, evidence says that the lamborexant, which is the orexin antagonist, which is available in India. Okay, there are some questions coming. I'll definitely go there. So lamborexant is something that can be tried. It does not have the cognitive deficits that is associated with that, and no morning grogginess. So that can definitely improve. And with regards to TV for relaxation, that is one of the easiest method, but the bright light is still affecting. If you are listening to something, so again, the knowledge of how to relax is abysmal in Indian setup. The easiest is phone, TV. Nothing more than that. Very few people listen to music. Some people, they do say, okay, I hear mantras. I'm happy with that. Podcast, I'm happy with that. And but I do train them. We do at our clinic, we do share them videos of music, white noise. Then we do teach them relaxation therapy, something as simple as deep breathing exercise of 4, 7, 8. As simple. This is something everybody, you can all suggest in your clinic. 4 seconds of inhaling, 7 seconds of holding, and 8 seconds of releasing. That's the easiest thing you can do. That you can try. So, and there is something called guided imagery. So rather, many of the time they find that their mind is going everywhere. So rather than the mind taking its own control, you guide it. You guide the imagery that's happening. You control, okay, I imagine myself in my favorite place, or you can imagine yourself being in some green meadows. You choose your scenario. It's all you doing the decision. You are taking control of it. The more you practice, the more you can do. But finding the right relaxation techniques, that is the cue. Everything does not work for everybody. People are like, I tried yoga, I tried this, did not work for me. So that doesn't mean they are doing it wrong or that doesn't work. It means you haven't found your relaxation technique. That would be my thing. Morning sunlight, very few people are getting sunlight. Morning sunlight to tweak our sleep cycle, sleep wake cycle is definitely necessary. So morning sunlight, I ask them, even if they can't walk around, I would suggest them they can even at least sit in an east facing area in the morning and at least get some morning sunlight. That would be my suggestion. Is there any other question? Relaxation. Yeah, relaxation is enjoying movies on TV. At least half an hour to 1 hour before bedtime, it can be stopped. Again, there's always this tug of war also, right? Me time versus we time versus sleep time. So that is also something that we always work on. It is very difficult, but you need to prioritize your sleep. Most of the time, we encroach the sleep timing. You have to give your body the adequate opportunity to sleep. So causes of sleep disorder, yes, hormonal changes, hot flashes, depression, intrusive thoughts, everything. So psychotherapy is definitely not just CBT for insomnia. How you manage your thoughts, mindfulness, it is beautiful. And it is very much in alignment with our traditional practices like Zen and yoga and everything. That can go a long way. So what works for you and actually practicing it, and even let's say the sleep issues get sorted somehow, and you were able to stop the medication, being proactive about all these lifestyle changes that should be lifelong. The medications don't have to be. That would be my go-to thing for this.
And the hot flashes need to be because of the deficiency of the hormones and estrogen, progesterone, etc. And the temperature management is deranged.
Definitely.
So how about adding the menopause hormones?
So
definitely for the hot flashes.
Yes, there is a lot of literature supporting that. Use of a bit of a combination, even transdermal patches, that is there. And there are, as you said, there are sleep aids. There are blankets which can control the change. There are beds, which like, okay, one person, the bed partner might prefer a different temperature. The lady might prefer a different temperature. There are beds you can alter your temperature preference also, but it's very costly. It's not for like everybody can manage it.
One of the other important things is also the
exercises.
sleep hygiene, no, madam. The sleep
That
hygiene,
goes without saying, yes.
because many a times it becomes, as you said, a vicious cycle, and they tend to think that I will prolong my sleep time a little more, probably, as you said, do some of these relaxation, regardless of, that window of going to bed. And as you said, when the levels come down is when you should hit the bed. I think if they stay awake beyond that, then it's going to be very, very difficult to get sleep. And it's almost, a fight till early morning hours, and then it carries on as daytime sleepiness and tiredness.
Yes, exactly.
So it's a question of also that hygiene that they develop and go to bed, hit the bed at the same time every day. Probably 5 days, 7 days, they might find it difficult, but after that, the body finds its routine, and then they
things will fall in place.
Yes, it will fall.
And even after all this, let's say you didn't improve, then sleep studies would be something that you want to see.
Yeah.
and see objectively what is actually happening. So that if there is any missed sleep apnea or periodically movement disorder, I wouldn't suggest sleep disorder unless and until there is a clear evidence or clinical evidence of sleep apnea or something or the other. If everything else is ruled out, then only, because it is a costly affair. It is not easily available. Insurance does not cover CPAP and even the study. So sleep study, if necessary, yes, I would suggest that.
Many of our Indian women are also anemic, madam.
Very.
You know, in perimenopause and menopause, that is what we see in our practice.
Very.
And that leads to the restlessness leg syndrome and the overall fatigue. And yeah, so, you know, correction of that really helps.
Yes, and
That
most of
and-
them, they might be already on antidepressant, which again worsens the restless leg syndrome. So finding the right antidepressant also is very tricky.
Madam, I understand that the sleep disorders have a big list of classification.
Yes.
And it is too complicated for me to understand. May I know from your practice, what would be the most common sleep disorder you have come across and how do we go about it?
Sure.
In this age
males,
group?
yeah, in males, definitely number one would be OSA. Definitely. In perimenopausal age group, mostly I see insomnia. And definitely OSA is also coming up. The awareness is very low. Okay, many people don't come up with snoring. Definitely they don't. And most of the time, the sleep disturbances would be the thing that they will come out with. They will not come up with the obvious thing. And sometimes they are very, hesitant to say that I snore. That is also very tricky to get that out. Or at least they will not come to the doctor with that complaint. So sleep apnea is definitely seen among the perimenopausal age group I have seen. Mostly it is insomnia. Then once insomnia is corrected, then I might go ahead with if a patient is obese, I feel that, there is some obstruction, Mallampati score is also a bit on the higher side, then yes, I will ask her to do a sleep study once sleep stabilizes and then look for any sleep apnea.
Madam, regarding the melatonin that you mentioned, so it is a sleep initiator.
Yes.
And how do you, besides the sustained release, which medication would you suggest to prescribe along with it for the maintenance?
So usually it depends on the scenario. It has to be very precision medicine that we go ahead with. Melatonin, if you look at evidence, it does not have much. Okay. But we in India, we use a lot of it. Melatonin as such for sleep onset, we will give, and especially in those with circadian rhythm disorders, it will be the drug of the choice. And sorry, you are asking what I give along with melatonin.
Yeah, for the maintenance, as you mentioned, that more for the sleep initiation.
Initiation.
Maybe they need much more for the prolonged sustained sleep.
So if you'll see the T halves, most of the time S-zopiclone. I see that in the Z class, that zopiclone is there, the S enantiomer of it. The S-zopiclone is very much available, and we do prescribe those medication, especially if there is a suspicion of OSA, because the benzodiazepine can cause respiratory depression. We don't want that also. So Z drugs is preferred. Orexin antagonist would be the best option at this point, but it is not feasible. They are still costly, coming to almost 50 to 60 rupees per tablet. If they can afford, that would be the best option.
Thank you very much, ma'am, for sharing your exclusive experience among those patients with sleep disturbances, which we understand very less. Thank you.
My pleasure.
Shall we move on to the next case?
Yes.
We have a 68-year-old Paris lady who's attained pre-menopause, who had a premature menopause at 37 years. She's never been on an HRT, and for the last 4 months, she feels a loss of strength in her hands. She does have a bilateral pain in the knee. A general practitioner has prescribed her calcium vitamin supplements, where there was not much satisfaction in the response. How can we evaluate and manage her? So the question will go to the obstetrician gynecologist. Dr. Vijay Lakshmi, would you like to add something?
Yes, madam. This lady has actually attained a premature menopause. So ideal will be that, she should have sought help earlier itself, because as you know, 46 and above is the natural age of menopause, and she is almost a decade earlier she has attained menopause. and there is going to be all the perimenopausal and the postmenopausal transition would have happened for her much earlier. And now at 68, we are probably looking at her in maybe severe osteopenia or even probably osteoporosis as well. So, see, she should have been started on MHT at that time. And and at this stage, we would like to evaluate her. We get the help of, or it's multidisciplinary assessment for her. We need to ask the orthopedicians also to have a look at her, assess her DEXA score, see how she is. And the overall loss, muscle loss that she's experiencing is probably the reason for her the
Weakness and
pains
tiredness.
and weakness and the general tiredness that she is experiencing. So it'll be a combination of starting her on the medications to increase her bone mineral density. So probably we would like to start her on so many options are available, maybe Tibolone and the other, if the orthopedicians sometimes prefer the injections and the calcitriol, everything can be started for the patient, but evaluate her, see what is the other reason. Is she diabetic? What are the other comorbids that she has? And then approach her. The treatment should be a combination of a multidisciplinary approach with the assessment. And that
May I have a question to Dr. Karthik regarding the assessment of these risk factors for sarcopenia in the when we address the patient? How will we analyze the risk factors that she has besides the age?
Yeah. So with respect to the, am I audible?
Yes.
Yeah. So with respect to the risk factors for
Yes.
sarcopenia, so I already showed in one of my slides about
Yes.
risk factors involved. With respect to that, with respect to fall, so here because it is very specific to muscle strength, then we can look at the standardized assessment of muscle strength, where we grade the muscle power from 1 to 5, 0 to 5. So we can grade those muscle power. One quick thing would be, how is it affecting her on a daily routine? And what are the kind of activities she finds it very difficult to do? So that would give us clues about what needs to be targeted, because each and every muscle has a specific purpose and they are involved in certain specific activities. As I was even in my talk, I'm saying that if it is sit to stand, the quadriceps has to work concentrically. Stand to sit, the quadriceps has to work eccentrically. Now, when I try to do any movement towards gravity, I need more control. So all those kind of nitty-gritties needs to be looked at, and based on that, we can look at one quick thing would be a look at the muscle mass, which can also give you a visual feedback, which can tell us that there is a sarcopenia there, a muscle atrophy can be evident. Many times it's very common, especially around the gluteal area, especially as the patient gets older and older, it becomes very evident in the gluteal area, because that is where you see maximum bulky muscles, and any muscle atrophy is very quick to be found there. And in addition to these things, we can go with some standardized testing as well. I mean, when I say testing, I'm talking about physical tests, which looks at the patient's ability to sit to stand, walk, balance, and all of that.
I
So
just
she has
went
already
through
been started on calcium and vitamin D. The thing is, many of the times these women stop the vitamin D. So I think with vitamin D, we have to also ask them to, sunlight exposure, something that most women, fail to do, our Indian women. And we have to tell them at least 20 minutes to half an hour walk when it is, the best time that their synthesis of vitamin D will take place, when it is in the region of between 10:30 to 11:30 in the morning, or in the afternoon between 2 to 3. So even 15-20 minutes of exposure to sunlight during that time, in addition to the vitamin D supplements that we are going to give them. So the 60,000 IU preparation, if we are going to give, we can probably initiate it at weekly dose and then put them on at least 2000 IU per day. And generally, it is recommended that we continue to give them the vitamin D. And in addition to putting them on inorganic calcium, take organic calcium in the form of calcium-rich food. So they should go in for a dietary modification also. That's what I usually advise my patients. You go on a diet which is more of green leafy vegetables and ragi and those kind of diet which is rich in calcium, that will really be helpful for them. And yeah.
Thank you, madam. Sir, regarding this fall prevention prediction wearable sensors, are there these instruments in the market available for our women in India? Or are they affordable?
Yeah, they are available, not readily affordable most of the time.
Okay.
They are available. And it, of course, because affordability plays a major role in getting it accessible.
Would you recommend to the people who are at risk?
Definitely, I would keep this as a last option because, as I had mentioned, there are two factors, extrinsic and intrinsic. And I would focus more on the intrinsic factor, which is muscle strength. And now this sensor is an extrinsic, right? It's going to give me an alert when I'm going to fall, right? So it's an extrinsic factor. So that would be my choice for patients who either are too weak or who too old. So then we will look at these sensors. But somebody who's 65, I would go for, I would not recommend that as the first choice.
So any role for creatine? I've come across in the literature, 5 grams of creatine per day, along with the exercises, which are resistant exercises, has proven to improve the sarcopenic state. They've also found some ghrelin agonists, which will promote secretion of increased growth hormone, which is also one of the factors which is in the postmenopausal women, which decreases. How would you like to share your experience with this?
We have not really worked with medication perspective when we have worked on patients with fall prevention. So I'm sure this is a new information for me. Probably I would look deeper into this and see how we can incorporate this as part of our program.
So these could be the areas where we could explore.
Sure.
Thank you very much, sir. So we have the third case, the 70-year-old postmenopausal lady complains of burning sensation and itching in the perineal area. Of course, there are no abnormal discharge, but once in a while there's a spotting per vagina. Local examination, it's a dry vagina, currently no bleeding. So how shall we address this urogenital atrophy? What do we have and what is the current status for the sexual activity which they are at loss? Should we focus on it?
Madam, this lady is 70 years, so probably almost 20 years postmenopausal. So, and the examination is revealing a very dry and atrophic vagina. So the spotting PV, first we'll have to always, when there's bleeding, postmenopausal, first is to rule out any other problems. We have to rule out endometrial causes. Are we looking at any early endometrial cancer? That is something that we have to evaluate her completely, ascertain, see whether her, do a transvaginal scan to look at the endometrial thickness, and even probably, if possible, take a pipel. Most of the time, it could probably be an atrophic endometritis or this, this pruritus that she's experiencing. And are we looking at some vaginal infection in addition to the, the atrophic vaginitis that she's experiencing? So that we have to really look at a proper gynecological examination, do a speculum, do a examination, and do a transvaginal. And if we are sure that it is not malignancy, then probably then we can consider, and if the issue is there, just giving them the estradiol cream, the Evelon, which is available for a short course of a week or two, will help with the pruritus and the perineal itching and all that she is experiencing. So it fits into the genitourinary syndrome of menopause, GSM. And as regards libido, I think probably we can see if the vaginal atrophy and the dryness is the issue, the estrogen creams will help, and some amount of lubrication. The creams also can be prescribed. And tibolone also can help to a certain extent in some women. So,
What will be your opinion on phytoestrogens? Role of phytoestrogens?
Although there are a lot of phytoestrogens that are available on the market and they are widely publicized and marketed, no major studies are actually, trials which really prove the proven efficacy of these phytoestrogens. So
Again, it's an area for exploration.
Yes, it
Thank
is
you
an
very
area
much,
for
ma'am.
exploration.
So that's the last case that we have. A 75-year-old multiparous lady with a 3rd-degree uterovaginal prolapse. She's with the decubitus ulcer and with multiple comorbidities and also stress urinary incontinence. How should we evaluate her and manage her? It is not easy to manage at this age, 75 years.
Yeah, see, she's 75 and multiple comorbidities, and with the presence of this prolapse with the decubitus ulcer. So I think we'll have to evaluate, and she will definitely require admission and healing of the prolapse and healing of the ulcer. So saline vaginal packing, and maybe we'll have to discuss about the options of pessary with her, because but with the advancements in anesthetic management, I think unless she's probably a very high risk case, I think we can probably go ahead and do a site specific repair, combine the vaginal hysterectomy with the site specific repair for her. Nowadays we do it, unless there are other issues also. And but it depends, and someone is asking that the pessary might just slip out. Yeah. In
That's
some
right,
women,
madam.
yeah, in some women it holds. So getting the right size of the pessary, more if we do not do, and the SUI, I think if we can probably put in a pessary and see whether it controls her the prolapses, prevented from coming down, and a bit of bladder training as well, because otherwise we should be thinking in terms of the TOT procedure. But since she's a very high risk candidate, but colpoclysis may not really address her SUI, and so I would say it's better to go in for a pessary or go in for a site specific repair.
These patients, especially the elderly, my concern is usually it's a neglected pessary. They may come back with worse complications, much dreadful complications.
Now, currently, I have 5-6 patients with me who come to me regularly for their pessary change once every
That's
3
very
months.
fortunate of you,
And
madam.
I have been managing them with that, because they don't. One is they are high risk candidates, number one, and number two. It's important that their family members are aware that we put in the pessary, and then we motivate them to bring them in once every 3 to 4 months for an assessment and pessary change. It is all how we motivate them and their family members. So this question
Shall
of
we
forgotten
consider
pessary should
giving
not be a thing of modern medicine, I feel. We have to definitely educate her and educate the family members that it is
Shall we
definitely.
consider low dose laser therapy for SUI, madam?
I have
Maybe those
maybe
specialists
our
can help us
chairperson
make
who
a decision.
Dr.
in-
Meena may have some opinion on that laser therapy for the SUI. There are so many of those periurethral injections and all that are available. But I have no experience with that, madam.
Thank you very much.
Thank you.
So we were at. So finally, what I've gone through in the literature, I didn't find much of literature to talk about the problems or monitoring, how they should be monitored yearly, 3 yearly, what are the problems there, how often it should be, each of them should be considered. I didn't really find any literature on those aspects. So we do re-emphasize that, especially the lady coming with the itching could be a vulval CA that we are quite missing, especially in that age group. So the cancer screening has to be meticulously done, the metabolic syndrome and the cardiovascular effects. I also noted that the hypothyroidism, the thyroid functions, dysfunctions that are noticed much more as the age and also with the women. We need to look into that aspect as well. And even a small dose of 25 microgram of thyroxine are suggested for these postmenopausal women and with their symptoms. Maybe the physicians could could help us understand better.
Yeah, if they have no other risk factors, probably, madam, but it's a little risky to put especially if they are in the euthyroid range. Maybe if they are TSH, because what endocrinologists generally feel is even a 4.5, close to 5 TSH is all right in that elderly age group. So they wouldn't want us to correct it. And sometimes the small amount of the 25 mics may cause toxic symptoms in some of these, and so it should be a little, we should be wary about prescribing it in euthyroid women. But subclinical hypothyroidism, yes, definitely we can address that issue. And as you said, it's always better to get our physician colleagues' opinion. And
yes.
Yeah.
Yes. So I would like to call upon the colleagues that the much felt need and which is not available, we should be working on the guidelines, how to monitor the geriatric patients and how to give the best quality of life for the geriatric patients. Maybe we have to work it out.
Yes, that's a must, madam. And one more
society-
thing is we also have to concentrate on the cancer aspect. Breast cancer screening should be done.
Yes.
And
Yes.
we should not forget all that when we are looking at the patient. And overall, looking at the patient is also important, apart from the urogenital atrophy and sleep disorders. That will make the life more comfortable. And cardiovascular risk factors also will be higher in this age group. And that also has to be kept in mind.
Yes.
That's what I
And
feel.
what we have not discussed is the social factors.
Yes.
Most often they are not being looked upon as a valuable
Citizen.
person in the society. So I think the government has to come out with some measures, programs to promote, to protect them. And
Many times
to
they are
support
depressed,
them.
madam. The depression itself is there. It sets in. These elderly, they feel neglected.
Lonely.
Yes,
They feel
loneliness
lonely.
and some amount of subclinical depression is there. That is something which really plays a very important aspect in their.
So maybe a social gathering interaction. They don't even get anybody to talk to or share that their emotions, or they live on memories. They
Yes,
mostly
ma'am.
live on memories. So I think we should think of something where they can be involved, keep them engaged, and then they could be some sort of take care of the social needs.
Madam, in that respect, you have so many of these elder homes, elder living
Yes.
communities which are coming up, which actually seem to be really helpful for when they decide to, because this empty nest syndrome sets in once the children are married and away. And there are so many of these elder living communities where I've seen even a few of my colleagues have kept their parents there who are 80 plus. And they're very happy there to be amongst same age, and they have a very good spirit of camaraderie, and they have their state of their mind is much better, and they quite enjoy it there. That's what I feel, Probably it's a time
culture
to.
of sorry,
Yeah.
I'm sorry, I thought you were done. The culture of self-help groups is very less in India,
Yes,
if you'll
ma'am.
see.
Yes.
So definitely something that we cannot think of. So most of the time, like once what happened in my ancestral home, there was this self-help, like a baby creche, but creche for senior citizens. So something like that, to give them, even if it's not an accommodation kind of setup, but something like
They can
a
visit
senior
and come.
creche can actually help them.
Yes, true, very true. Sir, and I also have a thing that I recently came across one of those videos, Karthik sir, that they have developed a wearable device which once the individual who wears it falls and hits the floor, it immediately inflates. It's something like our airbags, which are there in our cars, which inflates and which kind of protects their bony parts.
That's wonderful.
It was a very wonderful invention which was developed by one of those, and I saw a video of that. Might, I don't know whether it's commercially available, but I think they're kind of testing it. And it inflates in milliseconds. The moment the individual hits the ground, it immediately inflates and prevents them from getting any bony injury. Sounded very promising. Have you
Yeah, I have seen that videos.
I've seen the
It
video.
looks very good. I'm also not sure if it is available in the
whole
market.
body.
Only one thing I would like to share with respect to fall prevention here is that most of the time the fracture of hip happens when the fall is on the sideways, not forward or backward. Because when you fall backward, the gluteal muscle is cushion. It acts as a cushion, and it most of the time prevents a fracture. Okay, and if you fall forward, you tend to protect with your arms, and maybe you will hit on the
End
head,
up
but
have
not on
fracture
the
of the arm.
not on hip. But when you fall sideways, that's where it results in a hip fracture, and that is the side where we have the least amount of protection from muscles. It's a bony protrusion as well. So one of the key exercise or thing that we ask patients to do is to do side walking. Not forward walking, it's a side walking, so that they activate the hip abductors, and when they are losing balance on the sideways, they're able to step to the side, so that they can prevent a fall. Something that I would like to add here.
Thank you for
In
the
my,
tips, sir.
Thank
We will advise.
So in my training on this palliative care, where I happened to be at 12 days at Calicut, so I came to know about a very robust system, of volunteers attending to the aged, elderly, free of cost. Free of cost in a village or a setup. One person per day goes and takes care of that particular locality which has been mapped out, and everybody takes a turn. And I've also come across certain places where they have the palliative care elderly people, where the students march in on weekends. They will be entertaining them and making them happy, and so many things, make a paint, do a lot of things. And both the students and them, they have start enjoying a collaborative emotional bond. And I think our students should also be sensitized to the needs of this elderly. One day they're also going to go into this age. And I'm also have heard about in the Switzerland, when they are young and able, they go and work as caretakers for such people. And then that can be put in their accounts. When they need those kind of care, they could be retrieved. I think that's a very wonderful system
Idea.
that they have been using, like a bank of your service, and which can be withdrawn when you are when you need it later. Maybe our society should think of something
Pay
and
it
come up
forward
with.
kind of thing.
Hello?
Pardon, ma'am?
Hello?
Pay it forward, like you're
Yeah.
already booking for your
I
future.
can't
Yeah,
hear.
you're already booking your care.
Yeah.
So
And
Okay,
I think
சொல்லுங்க.
I've
our
also
society can think of some things of that
ஆமாங்க,
kind.
you have
Come up
chairperson
with
சொல்லிக்கலாமா? We are
something
time
which
up ன்னு. Okay.
what is needed, felt need for them.
So there are a lot of, old age facilities, not facilities as such, but a service provided by some rural areas in Rajasthan and all, where, ladies or men who are willing, they just have to spend 1 or 2 hours for, let us say, for really elderly, a lot of bedridden people, so that their kids or their children who are like 65, 70 years old, so they can take a break for themselves, so that
Excuse
the
me,
caregiver
please.
burden or the
Yeah.
compassion fatigue comes down.
Yeah.
So, and these
Please.
people can get some money also, not like a full-time job, just 1 or 2 hours. So
Yeah.
that is like a win-win situation kind of thing.
Dr.
So
Vijaya,
Excuse
please.
me,
We are
we
just
need
running.
to wrap up because there's a
okay.
platform needed for some other webinar, I guess, by Shield. So
Yeah, that is
we have
Thank you.
overrun.
Yeah, by half an hour.
Thank you. Thanks for understanding.
Thank you for giving the opportunity and some more time allowance for the discussions, which we could speak with our hearts out. Thank you very much.
Thank you.
Thank all
Thank
the
you very much.
panelists. Thank
Thank
the
you.
chairperson
Thank
and
you.
the organizers.
Thank
Thank
you.
you.
Thank you.
Have a good day.
Thank
Thank
you.
you. I
Thank
think
you.
these are wonderful webinar. My congratulations to all of you. And I will be in touch with all of you because I find it's a very, very distinguished faculty which spoke today.
It's a privilege, madam. It's a
Yeah,
privilege.
and we have to
Thank you.
utilize you for your research, further research in menopause now.
Thank you so
Thank you.
much. Thank
Thank
you.
you. Thank you very much.
Thank you.
Right.
Thank you, CMS, for the opportunity. Thank you, Vijaya madam.
Please, quiz result.
Thank you.
Sahiti.
Sahiti will now display the results of the quiz.
Sahiti. Call up Sahiti. Sandhya. Are the quiz results ready? Because then only.
Yes, ma'am.
Ready, ma? Sahiti.
Yes, ma'am, I'm sharing.
Yeah, please. It's really nice to see that all seniors and even
Really, all seniors.
who have won. Okay.
Okay.
And all of them are always very diligent and attending our programs. Congratulations to see within 4 minutes. So first one will be okay. Dr. Tara, madam always attends all programs, OXY programs, CMS programs, and congratulations, madam. And then followed by Dr. Shanmugam. So our active super senior in Chennai Menopause Society, and followed by Dr. Padmavati. So I congratulations to all the three winners. Thanks a lot. Shall we have a photo taken? Can you please switch on your... I think all have left. Okay.
I now request our Secretary of CMS, Dr. Meera ma'am, to deliver the vote of thanks. Ma'am is a consultant urogynecologist in Apollo Hospital, Chennai, and Chennai Specialty Clinic.
I thank everyone for being here, including our esteemed president, our chief guest, our guest of honor, Professor Madhuri Madam, all the faculty, the panelists, our MOC, and our academic partner, Shield, for this wonderful deliberation on a very rare topic of Geripause and educating us and enlightening us this very evening. Thank you all once and again, and hope to see you all soon. And as a teaser, we will be seeing more of this for the next few months and culminating in our grand annual conference on July 5 and 6.
So all of you all kindly mark the dates on your calendar. We will have a pre-congress workshop also earlier. So 4th, 5th, 6th.
Okay.
So
thank you.
Mark
Save
your
the dates, and we will be sending the flyer very soon. Thank you.
Yeah.
Thank you very
Thank you.
Okay, hearty congratulations to all of you. Such a good going. Good. Thank you. Thank you, madam.
Thank you.